And technology, of course, being in GE Healthcare, we're all about technology, industrial technology company is what we like to call ourselves. But that can actually fall into irrelevance if we don't have the entire healthcare system in order. And I think that was a huge lesson for us, which we've also learned from between COVID 1.0 and COVID 2.0. As a company and as a healthcare system, we've completely transformed ourselves to understand how we can address this better. So I'll share a little bit about our experiences, particularly in COVID 2.0 during the wave of, March through April, May, June. And there was the hardware element, of course. GE prides itself in hardware. So we had ventilators, we had CT scans, we had ultrasound machines and what have you. But that is a relatively easy problem to fix, right? Between 1.0 and 2.0, the major difference was in shoring up supplies. And we made sure we had enough equipment to deliver, at whichever hospital or primary care center required it. But that was not the real solution. The real solution was how we integrated with the system. I'll share one or two examples. CT scan. Now, typically, a CT scan center would perform 20 to 30 CT scans a day. It could typically be, a lung CT scan or a brain CT scan or whatever. But during COVID, during the peaks, the facilities were doing 100, in some cases, even 200 scans a day. Just think about it. It's mind-boggling. As a workflow solution to solve, it is mind-boggling. So we entered the system with some AI tools. And I'll speak a little bit later about AI and what part of it is overrated and what part of it is underrated. And what we provided solutions whereby a radiologist is able to make a much quicker diagnosis and scoring of the CT scan report and save between 50 and 60% of their time. So we address the access problem, we address the capacity problem using technology. Hardware was relatively easy. We just cranked up more systems than we usually do, but we were able to deliver actual patient interventions through these tools. Similarly, ultrasound is a tried and tested long-term product. It's been in the industry for decades. But we were able to deploy ultrasound machines at the point of care so that in real time, you're getting information about patients and their outcomes and whether they're progressing well or not. The third very interesting thing was tele-ICUs. Again, not a new concept. We've been talking about remote care. We've been talking about telemedicine for the last 20 years. Teleradiology has been around forever. So it's not really a big deal in that sense. But being able to put it together, work with the government, work with hospitals. You recall during that time, a lot of patients were staying in hotels and being taken care of by hospitals. How were they able to do that? They were able to do it because we were able to place monitors, patient monitors at the site where they were being taken care of. It was more of a telecom solution than a healthcare solution. We were able to rig these monitors to a central command center and have one critical care unit dispensing medical treatment for maybe 5x more patients than they would have ordinarily been able to take care of. I do have a slide, if you can pull that up. I'll close with that about some of the interventions that we tried out during COVID, which many of which we expect to stay for long. And I'll leave the audience with that slide for later, so I don't have to go through everything. But the point here is, teleradiology, tele-ICUs, these are technologies that are here to stay. We also saw the intervention of e-pharmacies, and they suddenly had their moment of glory. So yeah, I'm not going to go through each of these in detail, right? But the point I was making earlier was about telehealth and teleradiology, the intervention of artificial intelligence. But this also opened up some aspects of healthcare and technology, which were sort of new to us. And we're going to find those problems, problems or opportunities like cybersecurity concerns, privacy. How do we deal with that? During a crisis situation, it's like wartime, anything was fine. We just went in, all guns blazing with AI, with remote monitoring tools, with telemedicine. But when things get back to normal, we have to figure out how data privacy works. We also realized, Pushpa, one big problem that we have, and this is not just in India, but it's around the world, is data interoperability and portability. And this I see as a major opportunity. So the tech buffs in this audience, I think it would be worthwhile looking into this space quite a bit, because we have vast streams of data. Every hospital is digitally enabled now, right? I mean, the days of saying computerized lab or computerized pharmacy, that's old hat. But how do you make these data talk to each other? How do you make them relevant? How do you provide clinically relevant information to your doctor that they could make a decision with? That requires interoperability, that requires standardization, and the ability to integrate, lab data, radiology data, EMRs, electronic medical records, hospital information system, put them all together. So we can pull down this slide now, please. So the government, for example, the National Digital Health Mission is working on a health stack, much like they did in finance, with the UPI, the Unified Payment Interface. They're doing something like that for healthcare. And COVID, just like demonetization provided a thrust for UPI, COVID is providing a thrust for digital health, and we're likely to see a lot of that remaining long afterwards, Pushpa.
Shravan, thank you. And I think personally seen the impact of tele-ICU and AI in radiology, which just remained on the periphery before, but got pushed into arsenal we had to deal with this emergency. So glad to hear that in the company driving that impact in the middle of it all. In the end, you did talk about this whole technology thrust happening because of COVID, but also the policy stimulus. So do you see the overall ecosystem of level of digitization in healthcare evolving? Is the policy stimulus strong enough? Is healthcare delivery industry in India responding in terms of just ecosystem around digitization, policy stimulus, and appetite to digitize? Do we see India pushing forward to the next realm to enable the impact?
Pushpa, this is a great question. And sometimes we get so caught up in technology that we forget what it takes to make the whole system work. And the private sector often criticizes policy, but I think we've done an absolutely tremendous job. There are some areas which are not in sync, but I'm sure we'll iron those out. But to really answer this, I have to take you back 100 years. Right, when the 100 years ago, at the same time, the world was ravaged by another deadly disease, the Spanish influenza, and it wiped out tens of millions of people on a much lower base of population. So think about what a dramatic time it was. The life expectancy at birth 100 years ago, Pushpa, was half of what it is today. Right, a person born in the late 1910s or early 1920s could expect to live between 35 and 40 years. And this is just 2 or 3 generations ago. Think about it. Our grandparents' generation, when they were born, this was what they could expect. Today, life expectancy at birth in most countries around the world have exceeded 75. Some countries are talking 85. India is in the high 60s, early 70s. So every year, every 2 years, we have been adding a year to our life expectancy. Why is that? Obviously, we have a lot of new technology, right? We have, first of all, sanitation has improved. You have better treatments for sepsis, diabetes. A patient with a diagnosis of diabetes could not expect to live beyond the mid-40s 100 years ago. You have new surgical techniques, medical devices, and pharmaceuticals. All these transformations have been taking place over the last 100 years. But if you study the data, you read the literature, what has had a profound impact in population health, I'm not talking about individual health, population health, has been policy interventions and public health. Smallpox vaccine came out in the late 1700s. 1796, Jenner came up with the vaccine and a concept. But smallpox was just eradicated recently. And that happened only because it became a public health mission. And that's what's happening across. Now, even if you look at diabetes, if you're looking at non-communicable diseases, all this the needle is moving because of policy and industry, government, the professional practice. All of them need to come together for this to really click. I think now, coming straight to your question, I think there's been a tremendous amount of work done. but part of it has been suspended because of COVID, right? The Indian Health Policy of 2017, a magnificent document. For the first time, India is talking seriously about non-communicable diseases. How do we address diabetes, hypertension, cancer, various other diseases of, say, pregnancy and menopause? All these have come into a document, and there was some powerful work going on behind that. But naturally, it had to be partially suspended because of COVID. Now we need to think about the post-COVID world, whatever we're calling it, the new normal. We have to find a balance between COVID, non-COVID. One of the great tragedies, Pushpa, of COVID 2.0 was that patients who might have otherwise survived other diseases lost their lives because they did not seek treatment on time. This includes cancer. So a patient who might have been in stage 1 cancer, they kind of hung back, said, I'm going to ride out this wave and then go for treatment again. But guess what? When you come in stage 2 or stage 3, it may not be, you may not have enough resources to save that person's life or, maintain the same quality of life that they could have otherwise. I've been meeting a lot of hospital professionals and doctors asking them this question: where are your missing cancer patients? Fully 50% of cancer patients have not sought treatment during that 2 or 3 month window. And now what's happening is post-COVID, when things are normalizing, you have your normal flow of cancer patients that are coming in, as well as those who did not seek treatment during that time. So there's double that workload and COVID. And so things are in a state of disarray. So this is where the government needs to step in, policy needs to step in. We need to figure out logistics. We need to figure out better and different ways of delivering healthcare and access so that COVID patients and non-COVID patients have all the attention that they need and we're able to accelerate better outcomes.
Sure, Shravan. And I'm glad you take us back in time and remind us about how life expectancy is leapfrogged over the years. Probably lots of these cancer patients we're talking about wouldn't have been even diagnosed at one point, and we wouldn't have attributed that death to cancer because we didn't know it was cancer at that stage. And that's an area where care as we know it is evolving, and probably the next 10 years is going to see a much faster leapfrogging of care paradigm and care outcomes in oncology. So if we had to just look ahead in oncology and say, this is an area where in vitro, genomics, targeted therapies, everything is offering so much promise. How do you see all of these? And you all play into that so much. You have the big CDMRIs, which today help diagnose cancer. How's the diagnostics and treatment going to evolve, and how do you see GE participating in that over the next 10 years?
So, Pushpa, in many respects, the future of health is already here. Okay, because many bits of the puzzle are already being solved. Now we just need to put it together and create a cohesive story whereby the whole ecosystem is able to play to support a patient. I often speak about N of 1, right? So in order to make an intervention for one patient, a personalized approach, precision diagnostics as we call it, we need data from vast sources, right? So we need to understand, let's take lung cancer, for example. When I was in medical college in the 90s, first of all, lung cancer was a pretty morbid diagnosis. You'd be given 3 to 5 years, and it would be a miserable 3 to 5 years. There were only one or two kinds of tests and one or two kinds of therapies, and that would all be pretty tough. Chemotherapy, radiotherapy. The quality of life would also not be that great. Today, you have dozens of different diagnoses of cancer, of lung cancer alone. So it's not just small cell and non-small cell. Within small cell, you have so many categories, and these are diagnosed using huge amounts of data that are coming from genomics. Then you add a layer of your CT and MRI, molecular level imaging, and then you get your patient history, your population history. You map it all together, and each person is going to have a very different diagnosis, a very different therapeutic approach and clinical pathway. How can one individual clinician possibly do that? And it's not going to be easy. So we do need to rely on technology, but we should also be very careful how we apply and approach this technology. We see AI all around us. Every morning we play music on Alexa, but it's okay if Alexa decides to play U2 instead of Bon Jovi. It doesn't change anything. But if AI makes a slight mistake in diagnosing a lung cancer and suggests that you take something for non-small cell when you have to take something else, or it says ALK positive instead of something else, or your molecular image says something else, then it's going to have catastrophic consequences. And each layer, each variable adds a whole amount of complexity. It becomes exponentially more complex to deal with this outcome. So we speak very glibly about AI and clinical decision support tools, but it's actually very, very complicated because you need so much data. Look at automatic cars, right? Self-driven cars. It's taken Google and Apple and all these companies tens of millions of miles of driving for a car to safely be able to change lanes. But a 16-year-old is able to do it after 2 weeks behind the wheel. So there are a lot of nuances to healthcare, artificial intelligence. And what we're seeing now, to connect back to what I was saying earlier, many bits of the puzzle are being solved separately. So we do have AI that's able to score one particular part of a lung cancer, say. We do have something that is able to help us with genomics. We do have targeted therapy. This mutation works with that particular drug. We have clinical trials that are looking at real world evidence and putting it all together. Now we need the digital tools that will walk us through this entire patient journey, this patient continuum, and then come up with a diagnosis, treatment, monitoring plan. So this is incredibly exciting. This is the best time to be in healthcare because all this is happening now, and we're seeing some amazing interventions coming up during this time.
Thank you, Shravan. And I like how you keep taking us back to the health system. I think just the fact that you can't remove healthcare innovation and the technology from the overall system is just so obvious every minute we proceed in this conversation. As much as I think oncology is an area which is getting completely reshaped in terms of possibilities with such pervasive deployment of technology, probably take us back. Earlier too, you said India's done a lot. We spoke about maternal child health. It's been, as much as the communicable diseases was a problem in India, at one point, so was, maternity, women's health. We've improved our care outcomes substantially, but there is still. I see for uterine fibroids, for instance, globally, there is more image-guided ablation solutions getting commercialized. It's not sold in India. But there is technology reshaping paradigm of care. There is today recognition that healthcare is beyond, women's health is beyond one area. There is something as simple as PCOS is becoming a huge issue in India today. There's fibroids. There is, there's recognition that it needs attention. Do you see women's health coming of age? Do you see it getting transformed? Is technology playing a role there? How will it evolve again looking forward next 10 years?
So again, Pushpa, I think you made the point very nicely that women's health is not one issue, right? It's a collection of different issues which could happen during the lifetime. That there are diseases and conditions associated with puberty, with the menstrual cycle, with pregnancy, prenatal, antenatal, and then perimenopausal. So many issues are there. And then cervical cancer is a whole unsolved but highly solvable issue. Then, you walk into Tata Cancer Hospital in Bombay. I mean, on the outside, we think of cancer as one category, but you go in there and then there's an entire team dedicated towards breast cancer. And then intraductal versus other types, and so many types, and they are getting highly specialized. There's so much work going on there. Again, a tremendously exciting time to be in women's health because you're seeing more and more data come out from genomic studies, from population studies, from radio diagnoses, from molecular imaging. You're getting all this information. You're able to make better informed treatment decisions. In India, we do have one challenge where, maternal health and child health are often, spoken about simultaneously. And when you talk about child health, it's also about fetal care. And the outcomes of pregnancy around the world are absolutely phenomenal. In India, we are getting there. We've made some very good progress. If you follow the data, if you look at maternal mortality rate and infant mortality rate, they're getting closer and closer to some of the European or other developed markets, countries. But We also have to deal with issues such as prenatal testing, which might reveal the gender of an unborn child, right? So I'm connecting this with some of the technologies that we have, like we have some amazing ultrasound technology, which can tell you how the fetal heart is functioning, whether you need to make an intervention to any physical structure of the fetus and make sure that the fetus is healthy, growing well, etc. In India, we have a lot of restrictions to deploying this kind of technology, life-saving technology, not just for the fetus, but for the mother. Because of concerns that the gender might be revealed. So some of the best technology, by the way, let me show you this little gadget. Pushpa, this is a handheld ultrasound machine. Okay, it's the size of a phone. You can drop it on the floor, pick it up, it will still work. It works on near field technology. So as you're looking at a patient in real time, you can see their heartbeat or you can see any structure or function. We are not able to use these machines in India because of these guidelines. It could be potentially life-saving, but that's just how it is. We have to make do with it. But there are other sources of information. And I think the government is investing in women's health. Cervical cancer is an area where I think we could genuinely save lives by doing mass screening of cervical cancer, breast cancer, and so on, without necessarily, touching on any policy issues that might be inconvenient. But the women's health, cardiovascular care, these are all areas where technology can make a huge difference just by ensuring better access to quality clinical care.
The potential of that handheld ultrasound, Shravan, just seems so exciting, and I see how we can really democratize, in some ways, access to imaging, which is so critical to pregnancy and women's health. Um, I think the whole health system policy context becomes more and more clear, and this is so contextual. It is different in India in terms of socioeconomic implications and what it is in Mexico or Brazil or United States. But a lot's just also coming down to picking it up early, to getting people into a more seamless continuum of care. So it's all starting at primary care. Do we see a lot more? Because when you show me that handheld ultrasound, I'm just thinking ahead on what it means on more point of care diagnostics, invading primary care, a more connected continuum of care like you earlier described. So do we see primary care itself primary care providers getting more empowered, primary care becoming a more enabling aspect of the entire care continuum, empowered with technology in terms of how it can pick better and actually direct better through care continuum?
Pushpa, the glamour lies in tertiary care, but the real outcomes lie in primary care. Okay, so I'm so glad that you're making that point, because I don't think it is being emphasized enough. We need to invest as private sector, as government. We need to continue to invest. It's already happening, but continue to invest in primary care to make sure that patient who might get injured in a village or might suffer a myocardial infarction, working in the fields or something, has immediate access to healthcare. That is going to save more lives and extend life and improve the quality of life at a population level more than ever if we invest in that space. Imagine the power of having something like this at an ambulance, where you can triage a patient, a trauma patient, or by the way, this side is an abdominal ultrasound and this side replaces a stethoscope. This side of the ultrasound can render the stethoscope redundant, because it acts as an echocardiogram and it can tell you how your heart is behaving at this very point in time, and then determine whether a person needs to just be monitored or needs to undergo some sort of serious intervention. So empowering our primary care clinicians, our healthcare workers, our Anganwadi workers, this is where I think we need to spend most of our time, effort, and investment on for population outcomes. For individual outcomes, tertiary care. You go get the best and brightest, and you're sorted. So the future of healthcare is bright, Pushpa. I think it's already there. A lot of the pieces are already here. We just need to deploy it.
Thank you, Shravan. I think I love the optimism in this, but also just the confidence and understanding how much maturity there is in a lot of technology that's now coming in. The 2030 reality of leapfrogging of current care outcomes seems more and more tangible. I'm going to request tech team to help us get a video up. So GE Healthcare actually has a 2030. It's very coincidental that we intended to talk about envisioning healthcare for 2030. And GE has got a video on envisioning, care paradigm in 2030. So I'm going to request for a video to be played that Shravan to share. Then we'll come back to a conversation on how to make it happen.
The world changes, but some things never change. Difficult moments can make time stand still, but love can make a lifetime pass in the blink of an eye. You said I'd understand that someday, and then I blinked. And you were gone. Alarm off.
Good morning, Sophie. How did you sleep?
You tell me, Oz.
447 minutes of confirmed sleep, 34.2% REM. Slept like a baby.
Increase floor temperature.
Increasing floor temperature.
And start me a slow drip, will you? I'm going to take a shower.
Of course, Sophie. I have scheduled for you an appointment at the microclinic. Your full medical history and self-exam results from this morning have been confirmed, received. And your primary care doctor, Liz Childress, has been notified of your appointment.
Sophie, we've been expecting you. I'm Lily, your technologist. Let me show you to your personal pod.
Mom, where do I begin?
Our pods will help put you at ease. They're equipped with sensories.
I remember you telling me how you would sing to me before I was born.
It's going to be okay. Before we do any further testing, we're going to go over the results of your self-exam. But first, let's give you the sensory atmosphere you requested, shall we?
That you were convinced it was why I have such great taste in music.
Step up to the scanner and relax your body. Remain still. And 3, 2, 1. Good. Lift your arm above your head. Remain still. And 3, 2, 1. Good.
How the mere thought of me was all it took for love to grow stronger than anything you'd ever known. The invisible things that consume us.
Can I help you?
Love. The fear you had dealing with this, and how different it is for me today.
You look great. All right, now you're just gonna lay down for me.
Facing the very same thing that took you from me. You told me once, we can look so deeply into ourselves that we miss what's most important.
So, I'm afraid the MRI does show a suspicious lesion in the left breast. Based on appearances and outputs from the artificial intelligence application, probability of malignancy is high. That's the not so good news. The good news is that we caught it early, and when we look at global
I've been
data,
thinking about that lately.
we predict an excellent outcome for you.
But I see something now that was harder for you to see
Let's
back
talk
then.
about next steps.
Hope. Hope in the world that surrounds me, in the people here to guide me through. You told me it was something I'd find when I needed it most. And I have.
Sophie, you've got a really good team here. As I told you before, I think things are looking really good.
Hi, Mom. How's the news?
What I hoped for.
Look at her.
I just wish you could be here today to see it. And to meet your great-granddaughter. She has your smile.
Everything is set for tomorrow's party, Sophie.
GE believes in the power of emerging technologies to advance precision health and transform patient care. The outlook for healthcare has never been brighter.
I think the whole point of continuum of care, is so obvious through this whole video, and looking forward, and people are empowered with a small device in their hand to commence screening at home, initiate early care, have more personalized treatment care outcomes, brings everything together. That was so inspiring. Shravan, that actually takes me to a question from the audience. We were thinking we'll take it towards the end, but it's so relevant at this point. Let's just bring it on. This lady or gentleman's asking us, in the Indian context with 135 crore Indians, but also, an element of low resource, low income country, low resource setting. How, what technologies and how would be game changers in enabling prevention, prognosis, availability, affordability, diagnostic, treatment, post-treatment. So the whole continuum question in the Indian context, how do we empower care? Also in a case where consumerism is high in terms of healthcare, how do we make it happen here?
Absolutely. I'll answer that in a couple of different ways. It's a great question. Thank you for bringing it up. And as you said, it connects nicely with this story because there are so many moving parts as we realize now to healthcare. It's not just deploying one technology or one skill. We look at it from an access standpoint, right? And what is access? Access is a function of many things. We need technology, we need skill, we need logistics, we need scale, and then of course, cost. Cost is an inevitable part of the conversation. And there is a general sense, even amongst our groups, when we're talking, we have our WhatsApp groups where we're talking about, oh, this is getting really costly. But costly relative to what? I give you an example of leukemia, chronic myeloid leukemia. Would have been considered a death sentence if it happened in the 90s. Again, I take you back to when I was in med school. First of all, outcomes were very poor. And it would also cost nothing. It was about, say, 10,000 rupees in today's money, 10 to 20,000 rupees in today's money to use the kind of treatment that was available there. The outcomes were abysmal. The 5-year life expectancy at that point would be probably 25 to 30% at best. Quality of life would also be very poor. Today, it costs much more. It costs about, say, 100,000 rupees a year to treat a patient with leukemia. But they live normal lives, and their life expectancy is considered to be almost on par with a person who does not have leukemia. So yes, it costs 5 times as much, but the outcomes are, not even, you can't even compare the outcomes. So yes, cost of care, if you look at it in that sense, might be getting a little higher, but the outcomes are getting tremendously better. The investment that we're making towards public health and primary care is getting higher. We didn't have that in the 70s, 80s, 90s. Today, we have a lot of that. And that is how we're able to address healthcare needs of a country with 1.3, 1.4 billion people. By delivering, by getting the geographic piece, the logistical bit, by deploying technology, by adding skills, and then by scaling up. So this is how we address it. Now, the question is, you ask about consumerization of health, and then it goes back to the individual treatment decisions versus a community treatment decision. You ask a government official, how do you allocate your money? Resource allocation is a whole question that IAS officers are spending days and months trying to address. Do you spend 10 rupees for a sachet of oral rehydration solution, which can save the life of one child with cholera? Or do you spend a lakh of rupees for a patient who might live a few years longer with cancer? And these are not binary, right? You can't say, I shall do this and not that. You have to, there is a very nuanced way of approaching this. And the government is really putting in a tremendous amount of effort to figure this out. And the private sector is also playing a role in this. To address that question a little further, we have our insurance schemes. I believe that in future, 2030, I think even before 2030, there will be a convergence of all of these. You need to have some sort of a closed loop where reimbursement and healthcare go hand in hand, and they can't be two separate discussions. And then there is an incentive for the healthcare system to keep people healthy, and there is an incentive for the reimbursement agency to fund this and invest in this to make sure that patients are healthy. So those, and that is coming together also. We see a lot of these conversations between insurance and the healthcare delivery. It's already happened in many countries around the world where there's a single payer system for healthcare. Pushpa, to me, the second part, the question you asked me about consumerism, I would sort of turn that slightly towards empowerment. What you saw in the video and what you're starting to see now is all about consumer empowerment. And there are enough and more studies that tell us that an empowered consumer, empowered patient is going to have better clinical outcomes. They have better control over their decisions. They are actively engaged in their interventions. There's a lot of noise coming in from WhatsApp and Google. I'm not talking about that. I'm talking about actually understanding your disease, your treatment options, working with the clinician. And we also, sometimes, I'm a clinician, right? I'm a medical doctor, and I'm all about touch and feel and being with that patient and understanding what's happening in real time. But sometimes, in some cases, maybe you don't need that face-to-face physical interaction. You need to get the information across and make the patient aware and able to make that decision. One of the last trips that I had before the lockdown was flying through Auckland. And from check-in until you board the aircraft, you don't need to talk to any human being. And 10 years, 20 years ago, they said that high-touch industries like hospitality, aviation, we should have that human interaction and that interface for better passenger satisfaction or guest satisfaction. Guess what? I don't need that. Most people don't need that. I'd rather be empowered and have a better outcome than have all these touches. So that's something that you're going to see. Right now, your pharmacy is at the click of a button. And so your doctor is also going to be available at the click of a button. Most people are wearing an ECG machine and getting information in real time. You're getting your SpO2 in real time. So I say that the future is all about an empowered patient who is relying on technology. And the clinician, of course, has a role to play, an important role to play. But the nature of that role is changing.
Thank you, Shravan. And especially when you as a clinician acknowledge that, I think the change is here to stay. The empowered consumer has become more keen to be empowered over the last year and a half, given that they've embraced a lot more of this. I think the SpO2 tracking today, I've probably seen more people buy wearables for SpO2 tracking than they did before COVID happened. So clinically more. And it's encouraging to hear of the empowered consumer driving and taking more control and finally staying more engaged and really being able to benefit from everything that's happening. Before we conclude, one common theme again that I've been seeing in everything you're referring to is just the clinician, the data required to make it happen. The fact that this is no single entity driving this change. Multiple stakeholders involved in enabling it in the ecosystem, but also in terms of creating solutions that can actually get deployed. There seems to be a much more multi-stakeholder play than what we've historically seen. I mean, healthcare clinicians are important. They understand. Without them, you can't build an AI model because you don't understand connectivity of different data points. What can cause sepsis? What are you building into the model? The data is valuable. And the kind of data science research has become more multidisciplinary, and integrating that finally into what you said, CT or MRI or X-ray getting read. Are we innovating as a village? How is the way we innovate changed, and how should it be over the course of the next 10 years? How do we deliver this care possibility as an ecosystem?
So, Pushpa, this is a great question, and something that GE has spent an enormous amount of effort trying to figure out. You think about the last couple of decades, 2, 3 decades. What we were all doing better was, getting more depth in resolution, for example, right? So you have a CT scan, you start off with a single slice, 4 slice, 8 slice. Today you have 128 slice and beyond. And after a point, having more resolution in that is not going to have the same increment in terms of patient outcomes relative to the effort that you put in to deliver this level of resolution. Same goes for many other technologies. On the other hand, if you're able to use some kind of tool that can work on the data and then provide meaningful information and perhaps instruction to the caregiver, that is where you're going to see a lot of the difference coming in. And what we have realized as a company, and what perhaps many other companies have realized, is that no one company can solve this. Right? And we need to have those collaborations. You need to have that openness, and the government plays a major role in this. So coming back to the example I was talking about, the National Digital Health Mission, they are creating a framework to standardize data interoperability and portability. And once we have that, then you can have all the interventions that you need to say, okay, what do I do with this data? How can I make sense of it? How can I study patterns, population patterns, individual patient patterns, and then provide some layer of artificial intelligence or some algorithm which can deliver an outcome. And what GE has done, Edison, named after our founder, we have a project called Edison Accelerator. This is actually based in, it's a worldwide initiative, but we have a very strong presence in India. We have about 2,000 engineers in Bangalore. And that team has an Edison concept whereby we open this up for startups and for other technology companies and say that, look, here's what we have. We have this hardware. We have the ability to generate these results and these images. What can you do with it to fix a patient problem, to fix a system problem, a healthcare, service delivery problem? And there are different flavors of the season. Like the last set of startups that we onboarded were doing a lot of work in genomics. Previously, they were looking at image studies. How do you look at pattern recognition and come up with some kind of meaningful outcomes here? So we partnered with the external world extensively, with startups, with teaching institutions. So we do some work with some of the IITs, with IISc. So we are open for business, and it's not just GE, it's the whole healthcare industry that has learned that we have to work together if we need to make a real impact.
Thank you, Shravan. And on that note, we will conclude in the context, kind of a thing, realizing that if we're here to innovate as a village, in the audience, we've got startups, we've got IIT itself, we've got healthcare delivery stakeholders, and then we've got the investors. It's really for us to co-create. The vision is exciting, it's inspiring. What we've done from 1950s to 2020, we can do in much shorter time as we look ahead. So on that note, Shravan and I are excited to dream, excited to realize, those possibilities over the next decade, working together, working in collaboration, making it happen, improving care outcomes for 1.3 billion Indians. Thank you so much. It's been a pleasure. Thank you, Shravan.
Thank you so much, Pushpa. And thank you, IIT Bombay, for having me.
Thank you, IIT Bombay. This platform's just grown stronger and stronger, and we look forward to next year's conversation as much as the rest today. Thank you, everybody.